So hello everybody. I do see some faces in the room that I do not recognize. So I am Dr. Allison Asaro. I am the regional pediatrician for the Mid-Cumberland region. I've worked in this role since July of 2002. I'm clinical 4 days a week in 4 of our county health departments providing pediatric primary care, and then 1 day a week I am doing loads of different administrative tasks, and have gotten more involved in working with central office on some of these presentations, also doing pediatric physical assessment for the state, so some of you may have had that class recently. But today we are discussing Talk With Me Baby. This is an exciting program that was originally presented to us from somebody who worked for the Department of Health in Georgia. It is a program that reinforces the importance of healthy brain development in teaching infants and young children how to support their cognitive development, their language development, etc. Hopefully it is simply going to reinforce what we are doing with babies already, because we know that most of us speak to our babies during our clinical encounters, whether it's from the front window of the clinic or in patient rooms with WIC or primary care. So hopefully this information is just going to reinforce what you're doing already. So when we go ahead and talk about these objectives, we are talking about helping the families that we see at the health department. But remember that this program could extend out into the community setting as well. If people here are involved in community service, maybe organizations such as their church or nonprofits, this program's features can really be applied outside of the health department as well. And so what we're really trying to do here is we're trying to build families' capacity to provide what's called language nutrition with their babies. There are some comments here that we will go ahead and clarify in some of the future slides. We want to help families recognize the critical role they play in their baby's development and also in future school achievement, And we want to engage babies in direct conversation in every encounter, modeling what's called language nutrition practices to all families. When we engage families in language nutrition practices, we want to really incorporate strengths-based perspectives, and we want to incorporate things that are culturally competent into our care. An example of this that I'll use from my setting is that I have families that are overloaded with stressors on a day-to-day life, families that may have to work shifts that interfere with their ability to interact as much as they'd like to with their babies on a daily basis. And when that happens, we need to go ahead and focus on each family's individual ability to provide this care, rather than making families feel guilty about not being able to talk to their babies more throughout the day. And we also want to emphasize the importance of talking with babies in the home language in families who speak a language other than English at home. That is extremely important. Many of the families that I see at the health department do speak another language at home other than English, and it is not uncommon for me to see families who do believe that because the child will eventually be learning in English in the school system, that is the first and only language that the babies should be learning at this point, that their native language is not quite as important. And that is across the board very much false. We know that babies will learn better language-wise, cognitively, if we are speaking to them first and teaching them first in their home language. So when we go ahead and we talk about Talk With Me Baby, it's very important to understand why this program is important in the first place. So we know that health and education are intimately intertwined. And when I talk about education, it seems like we're talking about how is this baby going to learn to read, how is this baby going to learn math and science, and that is true, but remember that the overarching theme of this is we want children to have many opportunities and we want them to be successful. And successful to me, when I speak to families about this in clinic, is not only having a good job that you'd like that's making enough money for you to not be able to live month to month, it's also having opportunities, having choices. We want this baby to be passionate about what she or he does when they get to those later stages in life into adulthood. And we know that speaking to babies early actually can help affect some of those positive changes. So for instance, we know that men and women who complete a college education typically live at least 5 years longer than those who didn't graduate from high school. So as you can see here, for example, female college grads are expected to live until about 83.5 years, whereas those women that did not finish high school have a life expectancy of actually 5 years less, about 78.4 years total. Now there are exceptions to this, of course. We all know those tragic stories of folks, like my friend's father with a doctorate who had pancreatic cancer in his early 60s. But across the board, we know that in folks that complete a college education, that typically their lifespan and the quality of their health is better. We also know that maternal education affects the health of future generations. So here you see there's a lot of stuff on this slide here. So, going over what you see here, you see the infant mortality rate on this y-axis here on the left, and the infant mortality rate is the number of babies that die in the first year of life per 1,000 births. Across the bottom, you'll see total years of maternal educational attainment. So really what we know here is that the more years of education a mom has received, the more likely her infant is to survive and thrive. So you can see here, for instance, that in those moms who achieve that college education, getting 16 or more years of educational attainment, that about half as many babies die in that group as those that belong to the women who did not complete their high school education, and that's pretty profound. We also know that an additional 4 years of education reduces the risk of diabetes, reduces the risk of heart disease, reduces the risk of overweight, and most impressively, reduces the risk of smoking. You can see here that the correlation with the number of years of education and reducing risk of smoking is particularly dramatic at 12%. So when we talk about educational success, we talk about the third grade a lot. And I will be honest that as a pediatrician, I had never thought about this concept until I started presenting these Talk With Me Baby slides. So why do we talk about the third grade so often? Well, in the third grade, children's transition from learning to read to reading to learn. And unfortunately, in the state of Tennessee, at this time, only about 1 out of every 3 third and fourth graders is reading proficiently, which means that when we are transitioning from learning to read to reading to learn, that only 1 out of every 3 third and fourth grade students has their reading engagement and reading level in order to use that reading to continue their educational achievement. So Talk With Me Baby is intimately connected with this success because we know that if we can talk to babies more, we can improve their educational achievement and hopefully improve those numbers of third and fourth grade reading proficiency. So this is also particularly impressive. When children do not have reading proficiency in the third grade, they are 4 times more likely to drop out of high school. And when you go ahead and combine poverty with that, the lower reading proficiency also with poverty, these students are 6 times more likely to drop out of high school. And if you guys can think back to some of those slides that we just presented, that makes a big impact on an individual and a society at large. So what can we do about this? It sounds almost too simple. The most effective action parents can take to increase their baby's educational success and opportunities in life is to talk with their baby. So the first thing we want to do here is we want to learn the science behind language nutrition. We'll learn a little bit more about this in a second. So, as you guys can probably tell from these slides already, we're basically saying that early language exposure enhances brain development and academic success. What we know scientifically is that when kids are exposed to more language early, their brains develop in a healthier manner, third grade reading levels improve, high school graduation rates can increase, and long-term health improves overall. So when we think about early language exposure and how critical it is for a baby's brain development, we also remember that children's brains grow much more rapidly and form more connections between nerve cells or neurons in the brain before birth and in the first 3 years of life than at any other time period in their development. So when we think about these neural connections are essentially like the wiring in your house. You can think about them like the wiring in your house. You can think about them like the foundation of your house, but they are very integral to the structure. They are of the utmost importance to the structure of the brain, and those neural connections formed during this time provide the foundation for all learning later on in life. And not just learning, but our emotional processes, our ability to control impulses and regulate our emotions as well. So in addition to early and frequent language exposure, we also know gestational age matters quite a bit. And so for those of you that may not be medical per se, gestational age, of course, most of you know that it is the number of weeks that a baby spends in utero. So we know that a typical full-term pregnancy is a 40-week gestation period. And we know that infants born between 37 and 41 weeks typically are the most proficient reading group when we talk about the third grade. Now, when we go ahead and we look at this, are there less than 28-week-old babies that do very well cognitively at school? Of course, you guys probably know some of them from WIC or maybe your own families. So it's not to say that you're doomed by your gestational age, but it's to say that we have a much greater chance of becoming reading proficient if we can keep a mom healthy and keep her pregnancy in utero until she is at least 37 weeks. So this graphic can look kind of confusing to some, but its message is pretty clear. What we're seeing here is brain development over time. And so for those of you that can't see, the text on some of these slides is a little bit faint, but you'll see here over on the left, birth. Okay, and so the thing that is very impressive about this slide is what many of us know already, that sensory pathways and language development are actually developing in utero. Okay, so this doesn't all just start once we start to hear mom and dad's voice. This starts in utero, and especially with vision and hearing, you can see a very steep slope at the late part of our in utero development, which means that our sensory pathways are developing at a breakneck speed before we're even born. And so, when we think about those later stages of pregnancy, similarly, areas of the brain that are concerned with language are developing very quickly. And in those first months after birth, before a child utters their first intelligible word, we can see that language areas in the brain are literally exploding with potential. And so when we think about talking with babies, this is a very critical period in which babies need to hear lots of language, but also, as we'll talk about in a minute, language using the correct tone and context as well. So when we go ahead and think about higher cognitive function are those things that we need to actually start learning. And higher cognitive function that supports our thought processes is paralleling rapid expansion of abilities over this first year of life. So basically in this first year of life, we do not want to lose not a single day of developmental potential in this first year of life if it's at all possible. So the 30 million word gap, many of you guys may have heard of this study before. It was a study in the late 20th century that strove to prove that early language exposure is integral to language and cognitive development. What's really important about this study, for those of you that may read news journals about this or listened especially to a story that was on NPR over the last few years, is that the techniques of this study have definitely been questioned. But the overall message of this study about the importance of language exposure is clear, and it is still consistent with the scientific information that we know now about cognitive development in infants and young children. So in this particular study, it was essentially observed that language environments differed greatly depending on socioeconomic status. The researchers in this study essentially took about 42 families of different incomes, and essentially once a month a researcher came into the home, kind of hid in a corner of the house, and essentially recorded an hour's worth of speech in this child's particular home. These researchers came back to their labs and over many days and hours assessed the number of words that these babies were hearing in these different income level families. And what they noticed is children from middle income families in the study fared much better than children from low income families. Children from middle income families in general heard vastly more words per hour and had a much greater listening vocabulary when they went to kindergarten. The researchers then came to the conclusion that children who heard more words had a more abundant vocabulary, kind of the concept that we are drilling in with this presentation today. As you can see here, when we go ahead and look here, and you'll see the little unfortunate bags of money on the bottom of the slides indicate low, middle, and high income families. And what you can see here is that at the age of 3, children from high income families spoke about 1,100 words compared with the children from low-income families who spoke only about 500 words. And for those of you who take care of 3-year-olds either at home or in the clinic, you know that at the age of 3, especially in clinic, it's very important for children to be able to express themselves. And as we'll go over a little bit later in this presentation, kids that don't communicate as well tend to use their behavior as their language. And so in general, in my clinic, anecdotally, as a pediatrician, I see that the children around the age of 3 and 4 who do have the ability to speak more directly with me, more clearly with me, do tend to have an easier time coping with the stress of a medical visit. And again, that's just my anecdotal experience, but I think it's salient and it's been reproduced over and over again over the 17 years that I've practiced with the Department of Health. So research demonstrates that the single strongest predictor of a child's academic success is really not their socioeconomic status, even though we just stressed this in the last slides, the level of parental education, income, or ethnicity, but rather the quality and quantity of words spoken with the baby over the first 3 years of life. And what that means is that if we could take the stressors out of the lives of those lower income families in that 30 million word gap study, and those parents could be, messaged persistently to increase the language nutrition, which we'll talk about in a moment, of babies on a daily basis, those low-income children could theoretically produce as much language as those higher-income children in that study. And hopefully that makes sense to everybody. So we know that little brains need lots of words to grow and thrive. And so just similar to the healthy nutrition that we need to grow and thrive, from a skeletal perspective, from a height and weight perspective, we know that language nutrition is extremely important to babies. So in the same way that the quality of nutritious food differs and matters for a child's growth, the quality of language is also really, really important. And we know when kids get healthier language nutrition, that they tend to do better cognitively, and they are typically able to communicate with us and with their peers much better. So what is language nutrition? We've been using this concept and we haven't really been defining it yet. So the use of language that is sufficiently rich in engagement, quality, quantity, and context is language nutrition. We know that this type of healthy language nutrition nourishes the child not just socially, not just linguistically, but also neurologically. We talked about earlier how it really promotes lots of those healthy brain connections that we need to form the foundation of the brain. So quantity and quality of language, just like healthy food, is critical to brain development. And so what that means is it's not just how many words we say, but how we use them. So if we are spending the entire day yelling at our child, giving nothing but prohibitions, don't do this, don't do that, that language nutrition with the same number of words is not as nutritious, if you will, as the child that's getting more positive reinforcement, the child who's being included in more conversations, etc. So when we think about language content, children who are engaged with questions and who hear more positivity or affirmations do have better language nutrition. And we just, are constantly reinforcing this concept that better language nutrition promotes healthier neurologic outcomes as far as language and cognition is concerned. So it is natural and necessary for parents to use prohibitions on a daily basis. For those of you that have children at home, it is impossible to give positive affirmations to your child all day long. Children need to be redirected. Children need, at times to maybe experience a timeout for certain, previously delineated, errors in judgment. But what we do know is that when kids are engaged in more positive speak, more questions, more interactive, what we call serve and return interactions, that those babies have healthier language nutrition and subsequently develop language in a healthier way. Okay. So as we can see here, when children hear more questions and relatively more affirmations, they do have a more abundant vocabulary. So just going over, I keep looking here when I have these slides right in front of me. So we see child 1, child 2, and child 3 here. So obviously child 1 is hearing fewer words. They are hearing 13 million words versus child 3 with 45 million words. Child 1 is getting relatively fewer questions per hour versus child 3 who's getting 40 questions an hour. Child 1, yes, is getting prohibitions, but is also getting some affirmations as well. But child 3, look at child 3, is getting 5 prohibitions per hour. Those are don't do this, don't do that, don't touch this, etc. But is getting 32 affirmations. Does everyone see the correlations on this slide? What it basically means is when we engage children more in speech rather than talk at them in a negative context, we get, typically speaking, a better vocabulary by age 3. And that's a pretty dramatic difference. So child 1 speaking about half as many words as child 3. We know that parents are their baby's first and best teacher. So one thing to remember is technology just keeps on achieving newer and newer things for babies to, do without our interaction, as in apps and toys, etc. We know that parents are their baby's first and best teacher, and that no electronic form can match the capacity of an engaged human conversational partner. So when I, as a pediatrician, for instance, am in clinic and I see a family who, instead of trying to soothe the baby, for instance, pulls out, or a toddler tries to pull out the cell phone, play a YouTube video, distract with a game, etc., I will usually gently redirect that behavior. Sometimes I do a better job with it than others, but I will try to gently redirect that behavior and engage the parent in actually engaging with the child to help that child to regulate his or her emotions without just simple distraction. So remember, not only are these electronic devices not adequate from a learning perspective in comparison with an engaged human partner, they also aren't teaching our babies to regulate their emotions very well. They are teaching essentially that when we are upset, we distract ourselves. And as I mentioned earlier, this was actually a quote from a judge in Georgia, and I think it is so profound when we start to think about some of the direct interactions that we have with families in public and at the health department. When children do not have language, their behavior becomes their language. I would hope that most of us have recognized this in our care of families at the health department and beyond. So let's go ahead and go over this video. Now, there are probably many of you in this room that have seen this video already, and for those of you that have, it can be kind of upsetting. But it is also very profound in its message, so we'll go ahead and play it.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm my good girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
Okay, so that video, every time I watch it, it upsets me. So because, no mom wants to be that mom, right? But, we see that mom in the face of postpartum depression, for instance. We see that mom in the face of a mom who has multiple children and is maybe just overcome with stress, right? And we also see that, unfortunately, in our lobbies in the faces of babies and moms that are going through their cell phones, engaging with texting and technology rather than interacting with their child who may need something, down here who may be kind of ramping up that crying response, but not quite there yet, but mom's not noticing those early signs of need. So that video really, I can't even watch it anymore. It's very upsetting to me. So when we think about these key messages, then what do we know so far? So, and again, one of the things that you may notice with some of these trainings is that we are trying to drill home concepts. And so you're seeing and hearing the same messages a number of times so that basically you remember it. We know that early childhood is a critical period for brain development. Social engagement, or what we call serve and return. Think of that tennis match between caregiver and child where we're just lobbing that ball back and forth, with responses, body language, actual communication, etc. That social engagement is essential for language nutrition. We know the strongest predictor of academic success and also literacy is the quantity and quality of words heard in the first 3 years of life, or again, what we're now calling language nutrition. And you can show parents how and why to provide this nutrition to their babies in clinic. Even if you are in the front window of the clinic as a clerk, you can, when you say hi to a mom, also directly say hi to that baby that she just signed in. Even if that's all you do, you just engage that baby in language nutrition and you just modeled this very important concept for mom. And so don't feel like, well, my interaction with the family is so minimal, this isn't for me. This really is for everybody. Even when you're stuck at the grocery store, and there's a baby that's kind of eyeing you, in the checkout line, we don't want to be creepy individuals that, approach and talk to babies that are unrelated to us. But, we can provide quick, non-confrontational talk with me baby skills, even at Walmart. And so this is really, really important. We know that we want to communicate the importance of early language exposure with parents. Sorry if I just tapped on my microphone here. And we want to encourage parents to speak with their child in their home language. That is really, really important, and we'll reinforce that again in a moment. So what can we as health department staff and even concerned citizens do to promote healthy language development? I bet you guys could answer this question already. So we need to model or coach caregivers, and this does not need to be a formal process. And so you'll see here in the next few slides that there is a more formal process that was suggested by this program as it was originally created in the at the health department in Georgia. But I do want you to understand that even if you can only model a third of this, you are still providing good language nutrition modeling for families. So most of us are probably already doing this. In order to coach caregivers, we need to first believe that every parent has the power to help their child learn. So, we don't want to be those people that are like, God, that mom is hopeless. We don't want to be those people, because remember many slides ago, we talked about the importance not of socioeconomic factors, not of maternal education, et cetera. It's just the quantity and quality of how much we speak to babies. And so we know that every parent does have the power to help their child learn. We want to share knowledge and enthusiasm for language nutrition. So that just means, again, if you're at the front window signing in a family, you know this baby's name, potentially. Maybe you just signed him in for a WIC or just signed him in for vaccines. And while, greeting mom, you can also greet the baby directly. You can make eye contact with the baby. So we model this behavior and coach caregivers in order to increase the number of verbal transactions between parents and babies, which is essentially just increasing serve and return. So when we go ahead and we think about these concepts, if you're especially, for instance, in a WIC setting or in a primary care setting where you're maybe having a longer interaction with this family, a way, if you're wanting to start a formal discussion about how to go ahead and relay the importance of language nutrition, is first going ahead and using that motivational interviewing technique that a lot of us have heard about, and really asking a family, what are your hopes and dreams for your baby, right? So how many people know families that would say, well, I want my baby to not have good literacy, and I want my baby to drop out of high school, and I want my baby to have diabetes by the time she is 23. Is anyone going to say anything like that? I don't know that there is one single parent on the planet Earth that doesn't want their progeny to be successful. And so when we go ahead and we talk about this, it's not, hey, you need to talk with your baby more, you need to be more engaged, you really need to get over this, mental health crisis that you're having, and really be a circus clown for this child that talks all day to this child. We want to approach this from a motivational perspective, right? Like, what's in it for mom? Right? And what's in it for mom is increased bonding with her baby, which we know is really helpful, especially in the face of mental health issues. And then we also want to basically be teaching families that when we do this, especially in these first 3 years of life, especially in that first year of life, we are increasing exponentially opportunities for success in life, not just with cognitive development, but also with health. And so what will motivate this caregiver to talk to this baby? And it's imperative that we approach caregivers from a strengths-based perspective, collaborate with families, respect and recognize diversity, and also tailor coaching to the individual needs and perspectives of each family. When I think about this from my own pediatric perspective, again, I think about families. Perfect example, yesterday I saw a family in my clinic in Wilson County. In this particular family, mom lost her husband to cancer when he was in his late 20s, I believe. And she was left with about 5 children, one of whom was extremely small at the time. She had to go back to work. She didn't have an opportunity to be providing language nutrition all day for that particular child, because that particular child had to go into an informal daycare setting that she could afford, where the caregiver in that setting was not trained to provide early developmental interventions for this child, if that makes sense. And so what we talked about, I remember years ago with that particular mom, is that you have older children, and those older children have to read for school. They're practicing their reading skills. Could we engage those children in talking to the baby? When you're home and you're bathing the baby, you're feeding the baby, can you, instead of making those silent, mundane tasks, make them exciting tasks for your baby? Even though your baby's small, let's talk about body parts. Let's congratulate them for every ounce of formula that they've taken. There are lots of different ways to engage families in language over the few hours even that some parents have to spend with their children. We want to go ahead and also remember, in recognizing and respecting diversity, that that these concepts may not be as natural to certain folks as others. So I take care of people from many different countries, as y'all do, and it's not as natural for some parents to talk to their babies as others. And so some cultures are far more stoic, for instance. And so we just really want to make sure that we're tailoring this to a family, because we don't want families to leave after receiving this message thinking that their child is up the creek without a paddle because they work all day and they're not able to speak with their babies. We want to approach them from where their strengths are. And very importantly, as we'll learn later on, speaking to them in their home language, which should be the most comfortable language for the parent. So if we formally follow this process, which we may or may not do, we think about an I do, we do, you do approach. And this approach is used in a lot of different types of training, where we're learning a new skill for ourselves and then planning on teaching that skill to others. And so we want to remember that although this process of Talk With Me Baby works best when we engage, share, and encourage, as we see here, we don't want to feel locked in to this process or otherwise saddled by this process, because it may prevent us from even being able to provide a partial message, if that makes sense. So in my clinic, for instance, I do notice that some caregivers are far more timid about talking to their babies in front of me. So with those particular families, I'm not going to put them on the spot. I'm not going to make mom feel uncomfortable. I may just do the I do part. And it may be after a few encounters with this family, especially over the first year of life where we have a lot of preventive visits, that parent may get more comfortable with me and may then at a later date be able to engage a little bit more in this process. Or it may be less formal, and when I notice mom talking to her baby, I might go ahead and engage in we do before I do. And so the thing that is important about this process is, again, this process is best done in the I do, we do, you do format. But we don't want that to inhibit our ability to engage a family. If we can only do part of this, I think, as a pediatrician, anything that you can do to model this process is extremely helpful for the baby. We want this to be a positive experience. We don't want this to be a judgmental experience. And we want to also tailor it for your role in the clinic. So again, thinking about this as well, a clerk may only be able to do the I do piece of this. So when we do think about this in the more formal format, we know that in the I do phase, we're talking directly with that baby using questions and comments. So, if I'm seeing, the baby, I saw a sweet little baby yesterday named Romeo. And, the first thing I did when I came into the room was not greet the mom, but actually say, hello, Romeo, how are you doing? How is your umbilical stump since the last time you were here? Because I know mommy and daddy weren't very happy with how it looked. And so then I engaged with the parent, and she told me the umbilical stump looked great, etc. And so we want to direct these questions and comments to the baby in a child-directed way, which means that we're not going to talk like I'm talking here with you. We're also going to engage in something that we'll discuss in a moment called parentese, which is not just me having a verbal transaction with the baby, but having a quality verbal transaction with the baby, and we'll go over that in a moment. In the we do phase, we want to invite the caregiver to join us. That may or may not be awkward at first, especially when you're starting this process. You may give tips on how to talk to the baby. We'll go over that in some of the subsequent slides. But ideally in this interaction, we as caregivers are also interacting with the baby's caregiver in engaging in serve and return and verbal transactions that are quality and quantity with the baby. And in the you do phase, if you can get there, the caregiver is talking to the baby. You're providing supportive feedback and reinforcement. You're encouraging the caregiver's native language. So, if mom, speaks Spanish, for instance, and is trying to speak to the baby in English, encourage her, say, Mom, actually your baby is someday going to learn English much better if she becomes really strong in your native language, which is Spanish. So let's go ahead and speak to the baby in Spanish. So, and you may engage your interpreter in that at the time if you don't speak Spanish. I do speak Spanish, so we can do that directly with the family. It's really fun. And you do want to point out to parents how much feedback they're getting from the baby in this. Because remember, the feedback that babies give us when we talk to them and we engage in good language nutrition is kind of intoxicating. I don't know, I'm a pediatrician, so of course I love babies, but when babies are engaging with me, I tend to provide more verbal transactions back at the baby. So it's a really, fulfilling process. So, parents may ask you, what in the world do I talk to a baby about? Well, so beyond this slide, I always tell parents that babies are really good secret keepers. And so you can just tell them about what's going on in your daily life. But of course, we use greetings, we narrate actions, we direct attention, look at that airplane, look at that car, look at that puppy walking down the street. We can tell stories. Now remember, tell stories, not read stories. That is extremely important because remember, many of the families that we see in life don't have the literacy or the language skills necessarily to read the book as well as maybe you and I might be able to. So we talk about telling stories, not reading stories. And when we talk about using books, if parents don't have the literacy to read the words that are on the page, or perhaps the words on the page are in a different language from the language that the parent speaks, we just tell the parent then to narrate what they see on the page. So again, remember, this baby is not necessarily, especially early in life, following all the ebbs and flows of this particular book. They are getting benefit from the fact that we are verbally transacting with them. Okay, so obviously we can ask babies questions, and then a lot of soothing, of course, goes on, especially in those first couple of years of life. So when we think about good language nutrition and really optimizing these transactions, you've heard me say a few times that quantity is important, the number of words that we use, but also quality is extremely important. So when I saw Romeo yesterday, I didn't say, "Hey Romeo, how's it going? How's your belly button doing today?" It was, "Hi Romeo, good morning. How's your belly button doing? It was icky last time. Is it doing better? What do you think, Mommy?" So we use a higher pitched speech. We use short, simple, potentially even repeated phrases. We're elongating those consonants and vowels. So you heard how I elongated the name Romeo, for instance. We use a more melodic tone, varied intonation, exaggerating gestures and expressions, talking with your hands, for instance, and very precise pronunciation and grammar, because remember, the days of thinking that babies learn from goo goo gaga baby talk is pretty much over. We know that goo goo gaga baby talk can be serve and return, right? And that's not a negative, but when we think about babies learning speech, they learn best from us when we're speaking in the language we're most comfortable with and we're speaking clearly.
Down by 6. Time running
Fourth
out.
and long, he's never going to make it.
Formation, 4 wideouts.
Come on now.
Here comes the snap.
Do this for me. Come on now, I need this.
This is called parentese.
Look at daddy's boy. Look at daddy's boy. Look at daddy's boy.
How's my mighty man?
Babies love it. And this sing-song speech helps them learn language.
Hungry? Yes?
You're my big, strong girl.
This blue. C'est vraiment très
So
joli.
pitch your voice high
This is you, baby. Is that a nose?
and repeat your
Is that
words.
a panda bear's nose?
You're helping your baby learn sounds and words.
Go get some spaghetti.
Babies learn sounds and words from you.
For more information on parenting, visit pbsparents.org.
So in this particular short lesson, the key messages here is that we can all help families build skills to engage in rich language nutrition interactions with babies. And when we talk about babies, toddlers as well, of course, there are lots of language elements that we can use when we talk to them. Parentese and serve and return promote a child's language learning, and we use the I do, we do, you do approach. We want to model language nutrition by making the baby a conversational partner using the simple language elements that we talked about, like greetings, narrations, or asking questions. So when we think about this third lesson, then, this is kind of, bringing these concepts together. We want to talk about language nutrition for all families. So when we are communicating with families, we've reinforced some of these concepts already. It is really important that we want to be really clear in our messaging. So just the way that we're clear in talking to babies, we want to be clear in our messages to parents about this concept of talking with babies. And so, one thing that does break down some barriers when we are in a patient's room, especially when that patient may speak another language, is if it is a language that you do see a lot in the health departments, like Spanish, for instance, it's helpful to learn just a couple of simple greetings in some of those other languages. It really, I do speak Spanish, as a second language. And, it's amazing to me when I see, my excellent nurses working with interpreters who are also excellent, how still relieved a family is when I come into the room and can speak their language. Not everybody, is able to do that. I'm lucky enough that I was able to learn that in life. But remember that even if you can just learn an hola or, a few just greetings in the couple of most predominant languages that you see in clinic, it makes a big difference. It just breaks down a barrier and makes it seem like you're actually giving a hoot about this family that you're trying to take care of that day. So when we think about this, making our clients more comfortable, we also want to make sure that families are understanding the message by repeating and rephrasing these important concepts. And so, you guys that are, that have been working in the clinic for a long time, working with the public for a long time, we're good at, interpreting the language that our parents and caregivers are talking to us, but we also need to be able to interpret their body language somewhat. So as a pediatrician, for instance, I can tell without that parent telling me when I'm losing them. When they are disengaged with this process, it may be body language, it may be a crossing of the arms, a leaning away, a crossing of a leg away from me, for instance. It may tell me that the door is closed, that this parent is really not engaged in this concept, and if that's the case, I may not press with that, similar to how we talk about promoting healthy lifestyle in the clinic. We know that when folks are not engaged and we can't really bring them back into engagement, that sometimes our messages can be alienating. So, do go ahead and make sure that the parent is understanding, that they're not misunderstanding some of your concepts. Avoid acronyms and idioms, things, for instance, like, sayings in English that may not translate well with your interpreter into another language. In pediatrics, for instance, we talk about ACEs a lot, and our families, even, folks that we're teaching oftentimes in the health department, may not know that ACEs mean adverse childhood experiences. So just really speak in language that actually signifies what that collection of words actually says, for instance. Does that make sense to everybody? So because some of those colloquialisms are not going to translate well into another language. We want to, give and seek feedback. So, you may ask a mom, I noticed that, that you may not feel as confident with this process. You may not think that, you can teach your baby as well as I know that you can teach your baby. What do you think, what do you think may prevent you from talking to your baby in a way that is helpful to your baby at home? And it may be, well, mom says, well, I'm so tired and I take care of my neighbor's 3 kids and it just, I'm exhausted and I just don't feel like I can be animated enough to do some of these things that we're talking about with my baby. And if that's the case, we're going to put on the brakes, we're going to kind of move back a little bit, and we're going to talk about how to engage that individual mom or caregiver in a way that makes this a meaningful process. Does that make sense? Because again, very important that we do not want caregivers to leave our clinic thinking that because of their particular life structure at this time, that they're not able to engage their babies enough to create a successful environment for their child. That would be, I think, particularly devastating as a parent to leave a clinic feeling like that. We want to keep this message simple and, use gestures. As far as using gestures are concerned, remember when we're using gestures, when we're using our hands to speak, it just seems more personal, right? It makes the engagement seem a bit less rote. We don't want families to just think this is something that we have to do during every visit. We want families to know that we're doing this because we do truly care about their babies being successful, because we do. Hopefully you do. So when we see families that are culturally or linguistically diverse, we want to remind them that your cultural practices do not have to change in order to provide good language nutrition. We want to remind them that they are strongest in their home language. So I see many, many children right now in young families that have parents that speak dialect, or it may be that a mom speaks dialect only from Central America and a dad may speak dialect in Spanish. And that mom may feel that that dialect is not useful for the baby in the country that the baby is now going to be living and educated in. And that is 100% false. We know that this baby is going to develop neurologically in a better way, right, in a healthier way, if the first and strongest language is the home language. Okay, we also don't want babies to lose their home language. I see many heartbreaking instances of teenagers who have underused their home language so much that they can't communicate with their parents anymore. They may understand their parents but not be able to communicate back. And that can be really isolating for moms. And so we do want our families to be using their strongest language at home and leave it to their educators when they get into the school system to teach English. So exposure to 2 or more languages does not delay development. And so some families may think, well, isn't the baby going to be confused if they're hearing English from siblings, Spanish and dialect from dad, and dialect from mom? And the answer to that is no. The answer to that is ubiquitously no. Second language learning is easier when there's a strong foundation in the home language. And honestly, the more languages we learn, the more of our brain we're using. And so, that's an excellent, concept that we like to reinforce as well. Speaking in more than one language has not only socio-emotional benefits, but cognitive benefits as well. So when we think about this last section here and these key messages, remember that coaching is not just why we do this, but how we do this. So it does involve, asking the family, what do you think might be the obstacles to talking to your baby a little bit more? How do we break down those obstacles? Cultural practices do not have to change to enrich a child's language environment. That we are always recommending that the family use their home language to speak with the infants and toddlers. Strategies that can facilitate acceptance of language nutrition include motivational interviewing and individualized coaching. And remember, this is not meant to add a bunch of time to each of your clinical visits or encounters. This is something that hopefully we've all been doing during these clinical encounters, talking about how important it is to talk to and engage with babies. It's just giving it a bit more of a name, and it's putting a bit more scientific evidence behind it. And we definitely want to empathize and encourage all families that they can do this, especially for families that have situations that may make it or seemingly make it more difficult to provide this good language nutrition. Keep these messages simple. When babies come back for each individual visit, talk to parents. When we see that babies are expanding their language capacities, I always like to say, guess whose fault all this good language is? Yours, because we know that when parents are talking to their babies, the babies learn language better. And so, the families that I find that talk to their babies the most are babies who are leaps and bounds at 1 and 2 years old, producing more language than some of the babies that get less language nutrition at home. Providing this coaching to all families is extremely important, but we just, again, always have to consider, obstacles, the family's environmental considerations, shared family households, etc. And so, if we would like to at this point in time, we have typically little scenarios that we can engage with. We're not going to do that in the context of this course, as I mumble those words out because we've never done it in the context of my teaching. But if during this training in the future you are engaged in a process of maybe pairing up into small groups even to practice good language nutrition, this would be the time to do that. And so remember, the main message here, your baby is always listening, so make sure you're talking. Thank you guys very much.